David Back is Emeritus Professor of Pharmacology at the University of Liverpool and has led multiple studies on the pharmacology of antiviral drugs in HIV and hepatitis. More recently, he's been involved in COVID-19 studies, like all of us, I think, at the moment. David has authored over 520 scientific publications, is a former editor-in-chief of the British Journal of Clinical Pharmacology, and is the scientific lead on widely used online resources for healthcare professionals, which have gained numerous awards. And David, just so you know, you have featured prominently on so many ward rounds over the last 10 years that I've led, where we've been trying to work out which drug interactions we need to be worrying about, particularly in inpatients. In 2007, David was awarded the British Pharmacology Society Lilly Prize for outstanding contribution to clinical pharmacology, and in 2015, a European AIDS Clinical Society Lifetime Achievement Award. And David's going to be talking to us about something we all have to deal with in every single one of our different societies, about how to approach drug interactions with herbal medicines and supplements in complex patients. Over to you, David.
So thank you very much for the invitation to be part of this exciting symposium. So my task is to talk about herbal medicines and drug-drug interactions. My disclosures. The roadmap through the talk, we're going to initially look at what determines a drug interaction profile, then focus in on herbal medicines, and then on supplements, and bring some key learning points to bear. So what determines a drug-drug interaction profile? I think we all recognize that early on in drug development, initially through preclinical and then in early phase development studies, we need to gain an understanding of the disposition, the handling of a drug within the body, and therefore the potential for drug-drug interactions. So if we look at the kind of way that this would be done, for example, with a drug given orally, we need to understand its absorption, we need to understand its distribution, its metabolism, and its excretion. So here's a drug which is undergoing metabolism, and it's fairly straightforward in terms of, we believe it's undergoing phase 1, CYP3A metabolism primarily. So in the boxes, we have the example of a normal situation, normal enzyme, drug being metabolized, metabolites being the red circles. But that enzyme may be induced. That is, we double the amount of enzyme, and therefore the drug concentration will decrease, the metabolites will increase. The converse of this is that the enzyme could be inhibited, whereby the drug concentration will increase, metabolites go down. Now, how does this play out in terms of plasma concentrations? Well, shown in the right-hand side is the normal situation in the black line. With induction, in the green line, drug concentrations have gone down and therefore might fall below a minimum trough concentration very much earlier. On the other hand, the orange line shows drug concentrations increasing, maybe above a maximum safe concentration, and therefore potentially adverse effects. Now, we know that there are many drugs which can act, for example, as inhibitors, ritonavir, cobicistat, the boosters, azole antifungals, macrolide antibiotics, ciprofloxacin, they are examples. And also inducers. We're well used to rifampicin, carbamazepine, and older antiepileptics, and John's water herbal, and we'll mention that again, and efavirenz. These are just some examples where you can have induction and inhibition of enzymes. But that is not the only mechanism that we have to consider for drug interactions. So let's consider a drug, again, given orally. And here's the drug going into the gastrointestinal tract, undergoing dissolution. Within the gastrointestinal tract, there is the potential for a change in acid environment to affect the absorption. And we know that is true for atazanavir and rilpivirine, for example, which are acid dependent. Also, chelation with cations can alter the absorption. And we'll talk about this with supplements in a moment. We need to also recognize the importance of transport proteins, shown here initially in the wall of the intestine, the enterocyte, where you have efflux transporters. These are proteins which could be induced or inhibited. Uptake transporters into the hepatocyte, such as OATP1B1, again can be inhibited or affected, and therefore changing blood concentrations of a drug. And finally, transporters into the bile canaliculi. We also need to consider the kidney. It maybe isn't the main site in any way for drug interactions, but some interactions can take place in the proximal tubule, for example, again via transporters. So there are many mechanisms. And all of these things are important when we think about drug interactions from a clinical perspective in a patient with multimorbidity, in a patient who's taking multiple drugs, including non-prescription drugs, herbal supplements, etc. Maybe there's polydoctory, that is, many different healthcare professionals have an input into the management of the patient. And the antiretroviral drug could be a perpetrator of an interaction with a co-medication, or it could be the victim of an interaction whereby the co-medication is affecting that interaction. We're always concerned about reduced efficacy, be it of the HIV agent or the co-medication. We're concerned about potential adverse events. We're concerned about the cost implications. So we need help. And one of the things that we've tried to do with Liverpool resources is to give some help with all the different co-medications. If you look at the SMPC or the prescribing information, you have some drugs mentioned, but clearly not all co-medications that a patient may be taking. So we have these 4 green colors where we have a green, no interaction expected, where the benefit far, far outweighs any risk. On the other hand, at the other extreme, if the risk outweighs any benefit, then this is going to be a contraindication, should not be co-administered, etc. We have a yellow color, a weak interaction, PK interaction, but of no clinical relevance because of the therapeutic window. You could call that green if you want. And then we have the orange color. Orange is always the problem. It's the problem in traffic lights, isn't it? When you come to a traffic light, do you stop or do you go? Well, here we have the same. It may be an equipoise. So how do we manage an orange? And in this case, it may be a dose adjustment. It may be stopping a co-medication. It may be additional monitoring. So these are the issues that we face. Now, if we look through different antiretrovirals against nearly 800 co-medications in the Liverpool database, we can see that boosted antiretrovirals have less than 50% green. There are many drug interactions, some red and some orange. Similarly with efavirenz. But if you look at the integrase, non-boosted integrase inhibitors, you have a greater proportion of green. There are less interactions, very much less. There are still some red and some orange, and there are differences between the different integrase inhibitors, for example. Now, there are newer drugs. So here, for example, is doravirine. But more recently, there have been FDA approval of some other drugs. So for highly treatment experienced patients, and we're talking about complex patients, here are complex patients. And some colleagues discussing this at an IAS USA webinar recently went through a number of cases, and their summary was we need to explore all prior regimens, resistance testing, and then identify 2 fully active drugs if possible, using dolutegravir 50 milligrams twice daily, tenofovir as long as there's no K65R, 3TC or FTC, yes, despite resistance, and boosted darunavir being very important, and then these 2 recently FDA-approved drugs, fostemsavir and ebolusimab. But I just want to say a word about those 2 drugs, even though in your own territory it may not be available at this particular point in time. Fostemsavir is an interesting drug. The oral attachment inhibitor binds to HIV GP120. It's a prodrug. It has to be converted into the active form, which is temsavir. And this happens in the alkaline phosphatase in the gastrointestinal tract. And the temsavir is then rapidly absorbed, whereas the fostemsavir is not. However, temsavir per se is metabolized by cytochrome P450. It's transported by P-glycoprotein and BCRP, and it also inhibits a couple of transporters, which means that overall we have a drug interaction profile with 75% green, but a considerable number of orange colors. Management need to do something, and some reds. The reds are with inducers. So for example, a study showed a decrease in temsavir of 82% in the presence of rifampicin, clearly very important. Now we can look at ebolusimab, which is very different, this CD4-directed post-attachment inhibitor. It's a drug which is administered intravenously, a single loading dose of 2,000 milligrams, followed by a maintenance dose of 800 milligrams every 2 weeks. But notice that there are no interactions expected. This monoclonal antibody, our understanding of its mechanism of action and its target-mediated drug disposition, we do not expect drug-drug interactions. Which leads us to herbal medicines. Now, herbal medicines are widely used. This is real-world data showing the use of medicinal plants by traditional medicine practitioners for treating HIV and related conditions in Uganda. And they identified 103 different species being used. Now, here are some of the names. I don't know these particular preparations and I can't pronounce them. So we'll move to what we actually have in the Liverpool database in terms of herbal medicines. This is a prescribing resource listing 25 different, more commonly studied herbal medicines in the left-hand column and the different antiretrovirals across the top. Please don't try and read it other than get the impression that we have some reds and some orange colors, which means some contraindications and something to do. Let's bring this down to dolutegravir, efavirenz, and darunavir. And you can see listed, we have 10 of the commonly used herbals, but clearly there are a number of reds, don't co-administer, and quite a lot of the orange color with arrows, meaning the herbal may cause a decrease in antiretroviral exposure, or the upward arrow, the herbal may cause an increase in antiretroviral exposure. So please just note that as we see, what does it mean in practice? Well, if you're going to get induction, the herbal, normally some component will bind to a nuclear receptor such as PXR or RXR, and through transcription and translation, we get new protein, be it cytochrome P450 or a transporter. Inhibition is more direct and directly inhibiting the protein. Now, when you look at these herbals, the evidence is often laboratory-based in vitro evidence, and we have to then extrapolate this to clinical reality. There are sometimes case reports, occasionally PK data, but by and large, it is laboratory-based. Now, the most studied is St. John's wort, and St. John's wort is a herbal which does induce, as we've already said. It's well studied. The component which is active is hyperforin. That activates transcription and translation with new protein, enzymes, and transporters. More than 50 PK studies have been performed with hyperforin content of preparations between 0.1 and 40 milligrams per day. And we do understand that with this wide range of hyperforin, if you have products below 1 milligram of hyperforin, it's much less likely that you will have any interaction with enzymes. Now, it's always difficult, of course, to know maybe what the hyperforin content is. I just want a word about mumboir. Mumboir is a traditional medicine. It's a mix of various herbs in clay soil, which is molded into a bar. You can see it here on a market stall in Uganda. The bar is dry, taken as a suspension in water, and believed that mumboir helps alleviate pregnancy complications, in particularly shortening labor. Now, a study last year at IAS looked at the use of traditional medicine and also the effect of mumboir in pregnant HIV-positive women. And so the first aim was to determine the prevalence of traditional medicine use, and this was in the Dolphin 2 study, which is a large study looking at dolutegravir in late-stage pregnancy. Now note, in Kampala, 65% of the patients were taking traditional medicine, very different from Cape Town, South Africa, where it was less than 1%, but it was a high usage in Uganda. The other part of this study was in an animal model to show that concomitant administration of mumboir was associated with significantly reduced dolutegravir exposure in mice. And therefore the inference was it should be avoided in pregnant women receiving dolutegravir. Clearly very important. Now, one other point is that it's very, very important to recognize the importance of adherence. In this study recently published from AIDS Research and Therapy, potential challenges to sustain viral load suppression. The key point being optimal adherence to antiretroviral is certainly the key to sustain viral suppression. And one concern is always how concomitant use of traditional complementary medicine may impact adherence to antiretroviral therapy. So thirdly, to drug interactions with supplements. This is brief because with supplements, I think we well understand that integrase inhibitors bind to the integrase enzyme through magnesium at the active site of the enzyme. That's how it exerts its antiretroviral effect. However, if you've got cations present at the absorption site, then integrase can also bind and have a pharmacokinetic interaction. So oral cation administration with a high concentration in the gastrointestinal tract can alter the absorption of the drug. And we know that cations are variably present in supplements and multivitamin preparations. So importantly, looking at the integrase inhibitors, we have this orange color across the board for integrase, with once daily raltegravir being red. All integrase inhibitors are affected. There's a PK interaction by cation-containing antacids, and we have specific recommendations dependent on the integrase and dependent on the cation and possibly food. But in general, we need to ensure the separation of the integrase from cations. And these are just some of the advice given for two preparations: Triamec, the 3-drug, Dovato, the 2-drug dolutegravir 3TC, with aluminium, magnesium, and calcium. And generally, it's just take well separated in time, although with Dovato and calcium, the recommendation also is that it can be taken with food at the same time. So we have to look at the specific recommendations, realizing that many different preparations will have different amounts of cations. These are just some examples of multivitamin preparations. Notice here, 71 milligrams up to 780 milligrams of cations, 10-fold difference, which may be important. So it is quite a complex area to actually work through. And we know that recently there was a study presented with concomitant use of cations and integrase-based antiretroviral therapy associated with more than a double in the rate of virologic failure in a clinic in Delaware. And I want to finish with a case from the website of Clinical Cases DDIs of a 40-year-old woman diagnosed with HIV infection in 2004. She was on dolutegravir bacavir 3TC since April 2018, undetectable. And then in March 2019, viral load increased to 120, in June to 380. She claimed to be adherent, but they were able to do therapeutic drug monitoring. Dolutegravir was a low concentration. And then on consultation, she said she was taking magnesium supplements together with her Triamec every night. The patient was advised to stop the magnesium and to move it 2 hours either side, 2 hours before or 6 hours after the dolutegravir. And after several months, she achieved undetectable viral load. So the key learning points are really important. The guidelines recognize drug interactions need to be assessed. They're possible with all HIV agents, but boosted regimens and older NNRTIs have greatest risk, and polypharmacy is prevalent. We need to recognize the importance of herbals and supplements and always check. And my thanks to a wonderful team in Liverpool who supply resources for HIV, hepatology, and more recently COVID, and I hope they're useful to you. Thank you very much.
Thank you so much, David, for a wonderful lecture. And just to welcome back Clíona and David back to the panel discussion, we're going to start tackling what he's raised here. David, we work with your Liverpool group who've provided us amazing guidance in terms of which COVID molecules, especially the repurposed drugs, to bring into clinical trials here. We're busy evaluating them at the moment. So although I think they spend half their time rolling their eyes and sighing quietly, trying to explain to me how the drugs work. But let's open up the discussion. Please send in your questions. We've got several we're going to tackle here. We'll try and cram in as many as we can in the discussion. Clíona, what are the common sort of drugs that are a problem for you in terms of these interactions and things in your environment?
So it would be very much as David said, and I also have to thank very much on behalf of me and everybody I work with in Dublin who use the Liverpool tools all the time, every clinic, every day. So thank you. It would very much be the vitamin supplements, I think, you know, and the cations. And it's so easy because exactly as you said, David, people don't perceive them as medications and they don't necessarily mention them. We're lucky we have pharmacists in our clinic who, as the medicine is dispensed, check with the patients. But I think without that, we really often would totally miss stuff that people are taking. Those are our big ones. St. John's wort, I think, was more trendy in the past. I don't think we see as much of it anymore. And traditionally in Ireland, there isn't a huge use of herbal supplements.
Thanks, Clíona, for giving a shout out to pharmacists, because I actually think pharmacists, if you have that wonderful resource of having a good HIV pharmacist, then it's a fantastic.
It is just amazing. I agree.
Yeah, no, it's great. And they do a great job. We rely totally on pharmacists who input into our website, by the way. So it's pharmacists who really do most of the work, and I just sit at the top. But just looking. But I think, you know, I think this issue of perceiving what is being taken is really important, and it's actually very difficult to document. And in different settings, I think there are different issues about documenting. And I think probably in Francois' setting or in Africa, you know, we work closely with Uganda as well. There can be such a multitude of things, and there's so much sort of background and family and perceive that this would work for my grandma and that sort of thing. So there are just multiple issues, aren't there, Francois?
No, absolutely. And we have sort of the traditional medicine stream. We have, I guess what we call them all, the Western medicine stream, which I'm part of. And then we have a curious religious stream as well, which brings us very strange cultural conglomeration. People don't like volunteering when they're on supplements, but sometimes even if you ask them, I mean, one of my favorite replies once when I asked if people were taking traditional medicines, like, "Doctor, I'm a Christian." You know, like, that's very strange belief systems that operate, complicated belief systems around what is a medicine, what isn't. So yes, I agree. I think that and it evolves. It's quite faddish. You were talking about St. John's wort. It was very faddish maybe 10, 15 years ago. My sense is it's used a lot less in South Africa than before.
I think it's used very little in our setting as well. You're right. I mean, it was something that was being taken particularly by some of our HIV patients 10, 15 years ago. And I think it's quite hard. You know, I listed 20 or so different meds there, but there are just a multitude of things coming in, different cultures, different ethnicities, you know, whether it's Chinese medicine or Indian medicine, there are just multiple things, and we just don't know. And I think one of the other things, and I didn't really mention it on the talk, is that you can actually look at drug-induced liver injury in relation to some of these herbals, and it's not an insignificant problem.
So one of the questions we've got here, a couple actually, David. The first one was on SAM-E, and I had to, if some of the viewers haven't actually heard of that, I had to quickly Google that because I hadn't heard about it either. Some methionine extract, and I see there's another one here around kratom, which I also had to Google very quickly to try and work out what it was.
Yeah, I mean, S-adenosyl methionine has been used. There is no evidence at all. Again, with all of these things, there's very little study data, and I just showed that, you know, you might have in vitro, someone's put into a test tube and try to see if there's anything in the laboratory, but then actually extrapolating that to a meaningful clinical, you know, sequelae is quite difficult. But from all the knowledge about S-adenosyl SAM-E, S-adenosyl methionine, there's no evidence of an interaction. So that's clear. Kratom I'd know very little about, to be honest. What did you find out about it?
I just said in big capital letters, no efficacy data. So I was like, which I think I probably could have written. So, yeah. Every abstract conclusion on these drugs. Another question here is essentially asking about, is there sufficient cation content in food to cause a significant drug interaction or the absorption issue?
This has always been an interesting question, because if you look at the study data with dolutegravir, elbitelravir, with say calcium, for example, it was done with 1,200 milligrams of calcium. If you drink a glass of milk, there's probably 100 milligrams of whatever of calcium. So there's a huge difference. Now, where's the break point? And in other food stuff, you know, a cheese or a yogurt or whatever, where's the break point? My view is that you've got a fair bit of redundancy in the efficacy of a drug like dolutegravir. And so you've got to really reduce its absorption by 50% plus. And the problem with the cation interaction is not going to be important in every patient, but it's actually not knowing which patient it might be important in as part of a constellation of things that could just, you know, be critical in terms of having an adequate concentration. And that's always my worry. People say, well, where's all the evidence that, you know, that this cation is clinically important? And, you know, I showed one case report. There are case reports. And that's really, in a sense, what we rely on. We have PK data and we have some case reports. To me, that's enough to be cautious and to say, at least let's just separate out the cations when we know we've got cations on, you know, that we're taking cations.
So one of the things I took away from both a comment Clíona made earlier and yourself is just the role of the pharmacists in all of this, and in terms of guiding it. And traditionally in South Africa, certainly they haven't played that kind of role. I'm rushing off. I was just struck. Paul Sachs actually tweeted about how, or wrote a blog about how amazing in his practice in Boston, how amazing the pharmacists and how integral they were. And it's certainly something I'm going to be taking back. I don't know if you want to comment on that, David, as a last comment before we move out.
No, I mean, for me, and I think Clíona was nodding, the pharmacist role in the UK and in Ireland is absolutely critical to the management of the patients, and where that is possible and feasible, I would really advocate it.
Wonderful. Okay, I think let's stop there. We'll come back to the just as I'm doing the last presentation, we'll come back to some of these questions if we've got time at the end. So please just keep them coming.